Endometriosis. Why does it happen and who's at risk? I'm Dr. Lucky Seekon. I'm a double board certified OBGYN and REI, and I deal with endometriosis very often. Not every patient who has endometriosis necessarily is going to have infertility, and not every patient with infertility has endometriosis, but there is a really strong connection, and there's a lot of different ways that endo can cause infertility, whether it's through blocked tubes, depletion of egg count and egg quality happening more rapidly in women with endo, and no two cases are alike. For some people, it's only really involving the uterine muscle, and that's a subtype of endometriosis called adenomyosis that can sometimes, not always, lead to problems with implantation. So there's many different ways that endometriosis can look, and it isn't necessarily always going to cause problems with fertility. But because it's so prevalent, at least 1 in 10 women, and that's probably a huge underestimation, have endometriosis, and maybe around 20 to 30%, probably again an underestimation, of patients presenting for infertility treatment are thought to have endometriosis. So let's talk about why it happens and who's at risk. So endometriosis is a condition where cells that are like the tissue that line the inner cavity of the uterus, the endometrium, are found in places that they shouldn't be. So outside of the uterus. Most often that means in the pelvic cavity, involving the ovaries, the fallopian tubes, and other pelvic organs. But you can also find endometriosis in remote locations like the abdominal wall, even the brain, and in the cavity that surrounds our lungs. One of the major theories that could possibly explain why the pelvic cavity is the most common location to find endometriosis is this idea of retrograde menstruation. So all of us, when we have a menstrual period, we have the possibility of some of that menstrual fluid actually going the wrong way out of the tubes and landing in the pelvic cavity. And those displaced endometrial cells can act in an invasive way where they can implant and grow in the pelvic cavity and on organs in the pelvic cavity. And while most people have this retrograde flow, not everyone's going to get endometriosis. So there's got to be some other factors involved here. We definitely know that genetics plays a major role. If you have a first-degree relative with a known diagnosis of endometriosis, a mom, a sister, that will increase your risk of having endometriosis in your lifetime several-fold. There are also certain gene variants and mutations that have been identified to increase susceptibility, especially when it comes to certain genes that are involved in mediating an inflammatory process and regulation of your immune system. Immune dysfunction is another major contributing factor. We know that the immune system in people with endometriosis may not effectively recognize and clear out those misplaced endometrial cells, and this is what probably allows them to implant and grow. And then there's the theory of metaplasia. This is the idea that there can be cells outside of the uterus, even outside of the pelvic cavity, that can actually transform into endometrial-like cells under the right conditions. And this could help explain the theory behind why it can show up in remote locations like the brain or in the lung. There's also a possibility of these cells traveling through lymphatic fluid or through our bloodstream. And here's another interesting risk factor that a lot of people don't talk about: uterine anomalies. Yes, having a uterine anomaly that you're born with, such as a uterine septum or anything that obstructs menstrual outflow. So having an imperforate hymen that needed to be fixed when you were younger, anything that could cause more retrograde menstruation, whether it's a bicornuate uterus, a septum, any sort of different configuration to the uterus other than what it's supposed to be, can definitely predispose and be associated with a higher risk of endometriosis. And then we can't forget about environmental exposures. We know that chemicals like dioxins, endocrine disruptors, which are in so many of the different products and exposures in our environment, can alter the immune response, hormone signaling, and increase the risk of developing endo. So in reality, each case of endo may have a different cause. It could be a combination of causes, whether that's hormonal, genetics, immune response related, environmental triggers, or just your anatomy that you were born with. Understanding if you have any of these risk factors and knowing what to look for can be the key to getting a sooner diagnosis. And this is an important PSA. If you have periods that are so painful that they require treatment with around-the-clock medications like Advil, Tylenol, or even stronger meds, or if it causes you to miss work, school, interferes with your ability to function on a day-to-day basis, if you have associated symptoms whenever you get your period, really severe bloating, bowel or bladder symptoms around your cycle, or even pain with deep penetration during sex, known as dyspareunia, all of these are warning signs, red flags that you should get checked out. Traditionally, the diagnosis for endo is through something called a laparoscopy. It's a keyhole surgery done with a long, thin camera under anesthesia where they make an incision in your belly button to look around inside the abdominal and pelvic cavity. And I would say, that's something that's a little bit invasive. And nowadays, a lot of the times I'm making this diagnosis clinically, especially if someone has the symptoms that I listed and these symptoms are markedly improved or fully resolved when you're shutting down ovulation by using birth control, whether that's the pill, the patch, the ring. But even the progestin IUD, which doesn't necessarily shut down ovulation, can help with endo pain. So if you feel relief when you've started those types of medications, that could be a telltale sign. And if you speak to a doctor about this, which you should, but you feel dismissed, you feel like your pain is being normalized or ignored, seek another opinion. Know that you're not alone. It takes an average of 8 to 10 years for the average person to get diagnosed with endometriosis. And that's because of a long-standing history of women being ignored when it comes to their pain and their complaints in the medical system. But this is a really important thing to prioritize, as knowing this information ahead of time and not having that delay can help you avoid losing years of quality of life. And it can help you plan ahead, especially when it comes to your fertility, because we know that endometriosis can impact fertility. It doesn't always, but it can, and that's worth looking into for your future.